There's a particular kind of loneliness that nobody talks about, and it has nothing to do with living alone. It's the loneliness of sitting in your car in a parking lot, waiting for the urgency to pass before you walk into the store. It's the loneliness of declining a grandchild's invitation to the park because you don't know how long you'll be away from a bathroom. It's the loneliness of telling yourself, again and again, that this is just what aging looks like, that everyone your age must be quietly dealing with the same thing. If any of that sounds familiar, I need you to take a deep breath and stay with me for the next few minutes, because the story you've been telling yourself about this problem is almost certainly wrong. What you're experiencing is not a moral failing. It is not a character flaw. It is not the price you pay for getting older. It is a treatable medical condition with clear causes, identifiable triggers, and a stack of evidence-based solutions that the vast majority of people in your situation never hear about because nobody walks into a doctor's office and starts that conversation easily. I'm Dr. Matthew Reed, and today I want to walk you through everything I wish every one of my patients over 60 knew before they ever set foot in my office. We're going to cover what's really happening inside your body, the daily habits silently making it worse, and the treatments that actually work, beginning with the gentlest changes you can start tonight and ending with the options worth raising at your next appointment. If even one part of this video gives you back something you'd quietly given up, a long lunch, a movie without an aisle seat, a weekend trip, it will have been worth every minute. And while we're getting started, drop a comment right now and tell me, are you watching this for yourself or for someone you love? Both answers matter. Both kinds of people belong here. The machinery underneath it all. To understand why this changes after 60, you have to understand how the system was designed to work in the first place. Think of your bladder as a soft, muscular reservoir. It fills slowly through the day, expanding to accommodate the volume. When it reaches a certain threshold, nerves in the bladder wall send a signal upward to your brain, a polite tap on the shoulder telling you it's time to find a bathroom. Your brain replies by coordinating two things at once. The gatekeeper muscle that holds your bladder closed, called the urethral sphincter, releases its grip, while the bladder wall muscle, the detrusor, gently contracts to push urine out. When everything is working, the system is so seamless you barely think about it. But this entire choreography depends on tissues, nerves, muscles, and hormones all communicating cleanly. After 60, every single one of those components begins to change. And most explanations of incontinence get this wrong. They treat it as one problem, when in reality it's a category of problems with very different causes and very different paths forward. The 4 types and why you need to know yours. Identifying your type is the difference between treatment that works and treatment that wastes months of your life. Here are the 4, and what distinguishes each. Type 1. Urge incontinence. This is the one most people describe as a sudden, overwhelming need to go a wave that arrives with almost no warning and doesn't give you time to reach the bathroom. Many of my patients describe what's known as the key in the lock phenomenon. The moment you pull into your driveway or slide your key into the front door, the urge crashes in like a tidal wave. The cause here is an overactive detrusor muscle. Your bladder wall is firing off contractions when it shouldn't be, sending false alarms to your brain before the bladder is actually full. After 60, the nerve signals between bladder and brain lose some of their precision. Small triggers, a change in temperature, the sound of running water, a sip of coffee, an evening cocktail can set off involuntary contractions that simply wouldn't have happened 20 years earlier. This is the most common type in adults over 75. Type 2. Overflow incontinence. This one is less common, but easy to miss, and missing it has real consequences. It happens when the bladder never empties properly. It fills, then overfills, and eventually leaks in small continuous amounts. There's often no urgency at all, just a steady low-level dribble that's hard to explain. The cause is almost always an obstruction or a nerve problem. In men, an enlarged prostate is the most common culprit, physically blocking the path urine has to take. In both men and women, nerve damage from diabetes, spinal conditions, or certain medications can stop the bladder from contracting completely. If you're noticing constant low-level leakage without any real urge to go, please don't write it off as aging. Get evaluated. This type needs the underlying cause treated directly. Type 3. Stress incontinence. This is leaking that happens when sudden pressure is placed on the bladder. A cough, a sneeze, a hearty laugh, lifting a grocery bag, or even standing up too quickly from the couch. Important note, the word stress here has nothing to do with emotional stress. It refers purely to physical, mechanical pressure. The underlying problem is a weakened pelvic floor, the supportive hammock of muscle that cradles your bladder from below. In women, the combination of childbirth, the hormonal changes of menopause, and natural muscle loss with age progressively undermines that support. In men, prostate surgery is the most common trigger, though it can develop on its own. When the pelvic floor loses strength and tone, it can no longer maintain the closure pressure needed to keep urine in when the bladder gets a sudden squeeze from above. This is the most common type in women under 75. Type 4. Mixed incontinence. Exactly what the name suggests, both stress and urge incontinence happening in the same person. In women over 65, this is actually more common than either type on its own. The treatment plan has to address both fronts at once, which is precisely why a proper assessment matters before you start trying solutions. Why 60 is a turning point. Now that you can identify which type fits your experience, let's talk about why this all intensifies after 60. Because many of these reasons are not fixed facts of aging, they're modifiable. Medications you're already taking. This is one of the most overlooked drivers in older adults. Diuretics, prescribed for blood pressure or heart conditions, dramatically increase urine production. Alpha blockers for prostate issues relax the urethral muscles. Sedatives and sleep aids blunt the very signal that's supposed to wake you before an accident. Antihistamines can interfere with bladder muscle function. If your incontinence started or worsened around the time a new medication was added to your routine, that connection is worth raising with your doctor immediately. Shrinking bladder capacity. The bladder itself becomes less elastic with age. It simply holds less before triggering urgency. A 3-5 year old might comfortably hold 500 milliliters before feeling any urgency. A 7-0 year old might feel that same urgency at 250. The bathroom hasn't moved, your reservoir got smaller. Slower nerve signaling. The conversation between bladder and brain slows down with age. The warning that used to give you a comfortable 10 minutes now arrives with only 2. That shrinking window is exactly where accidents happen. Chronic conditions stacking up. Diabetes damages the nerves that control bladder signaling. Parkinson's disease disrupts the neurological coordination behind bladder control. Chronic constipation, far more common after 60, physically presses on the bladder from the adjacent bowel. Treating these underlying conditions often produces meaningful improvement in incontinence, even without any bladder-specific treatment. Hormonal shifts. In women, the drop in estrogen during and after menopause thins the tissues of the urethra and bladder, leaving them less elastic and more easily irritated. The urethral seal becomes harder to maintain. This is one of the reasons incontinence frequently worsens significantly in the years just after menopause, and it's also why localized estrogen therapy can be transformative for many women. Bring it up specifically with your gynecologist or urologist. Muscle loss everywhere. After 60, the body loses muscle mass at an accelerating pace, a process called sarcopenia. It affects every muscle in the body, including the pelvic floor. Without deliberate strengthening, those muscles weaken steadily, and so does the structural support they provide your bladder and urethra. The daily habits quietly making it worse. Here is where the most immediately actionable information lives, because there are everyday habits aggravating your bladder right now that you probably have no idea about. Constipation. Your bowel and bladder share the same pelvic neighborhood. A full or impacted bowel physically crowds the bladder, reducing its capacity and ramping up urgency. Chronic constipation is one of the most correctable contributors to incontinence, and one that almost no one thinks to address. Alcohol, a double offender. Alcohol is both a diuretic, it increases urine production, and a direct bladder irritant. If nighttime leakage or evening incontinence is your main concern, alcohol consumption in the hours before bed is among the most direct contributing factors you can change. Not drinking enough water. This one stuns people every time. Many of those struggling with incontinence deliberately limit their fluids. Figuring less in means less out. The problem: concentrated urine is far more irritating to the bladder wall than diluted urine. Restriction actually causes more urgency, not less. Mild dehydration makes an overactive bladder worse, not better. The goal is steady, moderate hydration spread across the day, not restriction. Caffeine. Coffee, tea, energy drinks, many sodas. Caffeine is a well-documented direct bladder irritant. It increases urine production and triggers detrusor muscle contractions. If you have urge incontinence and you're drinking 3 cups of coffee a day, you are quietly making it worse every single morning. The evidence on cutting caffeine for urge incontinence is consistent and compelling. Drinking too much at once. The mirror image of restriction. A large volume of fluid arriving suddenly overwhelms the bladder's capacity. Sipping steadily throughout the day suddenly overwhelms the bladder's capacity. Sipping steadily throughout the day is dramatically better for bladder management than chugging a big glass of water all at once. Artificial sweeteners. A lesser-known irritant, aspartame and saccharin in particular, have been linked to bladder urgency in sensitive individuals, worth eliminating to see if you're one of them. Carbonated drinks. The carbonation itself, regardless of caffeine or alcohol content, is a bladder irritant for many people. Yes, that includes plain sparkling water. What actually works? Treatments? In order of where to begin? Now to the part that matters most. The options here are far better than most people realize. I'm walking through them, starting with the gentlest, lowest risk interventions and moving toward the more invasive, because that is exactly the order they should be tried in. 1. Bladder training. For urge incontinence, this is the foundational treatment, and it is remarkably effective. The premise: your bladder has developed bad habits. Every time it sends an urgency signal and gets immediately answered with a trip to the bathroom, that pattern gets reinforced. The bladder learns to fire those signals earlier and more intensely. Bladder training rewrites that pattern. Here's how it works. You set a fixed urination schedule every 90 minutes, for example, and stick to it regardless of urgency. When the urgency strikes between scheduled intervals, you use specific suppression techniques rather than rushing to the bathroom. Those techniques include stopping completely and standing still rather than hurrying. Rushing actually increases intra-abdominal pressure and makes urgency worse. Taking slow, deliberate breaths. Deliberately contracting the pelvic floor, which reflexively tells the detrusor muscle to relax. Over time, you stretch the interval from 90 minutes to 2 hours, then 2.5, working toward a comfortable 3 to 4 hour window. Research consistently shows bladder training cuts urgency episodes by 50 to 80% in patients who stick with it. No medication required. 2. Dietary adjustment. We already covered the irritants. Eliminating them systematically one at a time, so you can pinpoint your own personal triggers, is a zero-cost, zero-side-effect intervention that often produces noticeable results within days. Start with caffeine. Cut your intake in half for 2 weeks and observe. Then reassess. 3. Pelvic floor exercises, Kegels done correctly. This is the most evidence-supported home treatment for stress and mixed incontinence, and it works for both men and women. The pelvic floor muscles are the ones you'd contract if you were trying to stop urinating midstream. That's the muscle group we're isolating. A landmark review in the Cochrane database, the gold standard of medical evidence synthesis, found that women receiving structured pelvic floor training were significantly more likely to report cure of incontinence than those receiving no treatment. Similar findings exist for men recovering from prostate surgery. The make or break factor is technique. Most people who try Kegels and quit do so because they were doing them wrong, squeezing the wrong muscles, holding for too short a time, or skipping the consistency required to see results. Here's the correct method. Contract the pelvic floor, not your abdomen, not your buttocks, not your thighs, and hold for 5 to 10 seconds. Release fully for the same duration. That's 1 repetition. Build up to 3 sets of 10 repetitions daily. Results typically begin appearing within 6 to 12 weeks of consistent practice, with significant improvement by 12 to 16 weeks. If you're unsure whether you're contracting the right muscles, a single session with a pelvic floor physiotherapist will tell you instantly. 4. Pelvic floor physiotherapy. If there is one piece of advice I want you to take from this entire video, it is this. Book an appointment with a pelvic floor physiotherapist before you ever conclude that incontinence is permanent. These are specialized physical therapists trained specifically in assessing and rehabilitating the pelvic floor. They can determine whether your muscles are weak, tight, uncoordinated, or some combination of all three. They guide you through correct training, biofeedback, and bladder retraining in a structured, individualized way. The outcomes documented in research are consistently better than self-directed exercise. A single assessment can save you months of effort spent doing the wrong exercise incorrectly. I know many people feel embarrassed about scheduling that appointment. I genuinely understand. But pelvic floor physiotherapists spend every working day on this exact issue. There is nothing you'll say or describe that will surprise them. And what's waiting on the other side of that visit is often, for my patients, life-changing. 5. Localized estrogen therapy for women. Distinct from systemic hormone replacement therapy, localized vaginal estrogen delivered as a cream, ring, or pessary works directly on the urethral and vaginal tissues with minimal systemic absorption. It restores the tissue integrity that estrogen loss erodes over time. Multiple studies show it reduces urgency, frequency, and stress leakage in postmenopausal women. Importantly, it's considered safe for many women who can't take systemic hormones for other reasons. Bring it up specifically with your gynecologist or urogynecologist. It's a targeted conversation worth having. 6. Weight management. Excess abdominal weight increases intra-abdominal pressure, constantly placing relentless downward force on the pelvic floor. Research in the New England Journal of Medicine found that even a modest 5 to 10% weight reduction produced a significant drop in stress incontinence episodes in overweight women. The mechanism is direct and mechanical. Less pressure pushing down means less demand on the muscles, holding everything up. 7. Medication. For urge incontinence specifically, a class called antimuscarinics oxybutynin tolterodine reduces involuntary bladder contractions. A newer class called beta-3 agonists, most commonly, mirabegron relaxes the bladder muscle with fewer side effects. These are legitimate tools, but I need to be direct. In older adults, antimuscarinics in particular come with a side effect profile that warrants serious attention. Dry mouth, constipation, blurred vision, and crucially, an association with cognitive impairment when used long-term in older adults. Before agreeing to any bladder medication, have this specific conversation. Given my age and overall health, which medication has the best safety profile for me long-term? Beta-3 agonists are generally better tolerated in older adults and are worth raising by name. 8. Surgery. As a last resort, not a first resort. Surgery is a real and sometimes appropriate option, primarily for severe stress incontinence that hasn't responded to conservative treatment. Procedures like the mid-urethral sling for women and artificial urinary sphincter placement for men have strong evidence bases. But surgery should come after a genuine attempt at conservative treatment, typically at least 3 to 6 months of consistent pelvic floor work and bladder retraining, not as the opening move. If a surgeon recommends an immediate surgical solution without first walking through pelvic floor physiotherapy and bladder training, get a second opinion. Always. How to talk to your doctor. Most people who see a doctor about incontinence leave with a prescription and very little else. Here's how to make that appointment work harder for you. Say this. Before we discuss medication, I'd like to understand which type of incontinence I have and whether pelvic floor physiotherapy and bladder training would be appropriate first-line options for me. Ask this. Are any of the medications I'm currently taking potentially contributing to this? And this. Which lifestyle changes have the strongest evidence behind them for my specific type? If your doctor brushes these questions off or moves straight to writing a prescription, you are absolutely entitled to ask for a referral to a urogynecologist or urologist who specializes in bladder dysfunction. That's a specialty with far more sophisticated assessment tools and a much fuller toolkit. What to take away? Here's what I want you holding on to when this video ends. Urinary incontinence after 60 is common. But common is not the same as inevitable. And it is absolutely not something you're meant to manage in silence, quietly cutting plans short, mapping the nearest exit in every room, shrinking your life to fit around a problem that has real, accessible solutions. The path forward almost always begins with the smallest steps: dietary adjustments, pelvic floor training, bladder retraining, long before it needs to involve medication or surgery. And a single hour with a pelvic floor physiotherapist can do more for you than months of guessing alone in your bathroom. If this video gave you something useful, a name for what you've been carrying, a question to bring to your doctor, or simply the relief of knowing you are not the only person dealing with this, please hit the like button and share it with someone who might need to hear it. Leave a comment below. Have you been quietly struggling with this? Or have you found something that genuinely helped? Your honesty in the comments might be exactly what someone else needs to read tonight. And subscribe if you haven't already, because next week I'm covering the 5 medications most commonly prescribed to adults over 60 that leading geriatric specialists are now reconsidering. There's a real chance you're taking one of them right now. Take care.